Hello, I'm Ted Yap. I'm a consultant surgeon based in Guy's and St Thomas's in London, and I'm also the lead for our multidisciplinary clinics for Klinefelters in St Thomas's, which is a national access clinic for the rest of the United Kingdom. So I'm going to talk about gender identity in Klinefelter syndrome, which is an interesting and quite a new topic in the field of Klinefelter research. I have no conflicts of interest to declare. Okay, so first of all, what is gender identity? So it's really a person's sense of being male, female, both in between, or something other. What influences it? Well, your hormones, your physical characteristics, the environment, and how society views certain characteristics as well. Gender questioning is the process where an individual comes to really question how useful or how valid their current biological assigned gender is, biological sex or assigned gender is. And in itself, gender questioning is quite difficult to diagnose. We don't have a specific set of criteria to define when a patient is or when a person is gender questioning or not. What would be useful to think about gender is in the context of the genderbread person. So this is a scheme that really looks at gender in terms of different characteristics. Gender identity, for example, is the womanness or the manness that you feel yourself, which is different from your expression of gender, which is the femininity or the masculinity that you express. And that is different from anatomical sex and different from sexual leanings as well. So sexual attraction, romantic attraction. So most children actually between the ages of 18 and 24 months can recognize and label genders. They identify others as girls, for example, and others as boys. And they can also label their own gender by the time they reach the age of 3. But with societal views, with parental views and other factors, their view of their own gender and genders around them may change. And especially their genders, they may learn to behave in different ways that don't reflect what they truly feel. So at age 5 or 6, most children are quite rigid actually about their gender and preferences. And this rigidity actually becomes more flexible with age, especially around puberty. Gender dysphoria, however, is a medical condition that's defined as a marked incongruence or dissonance between one's experienced or expressed gender and one's assigned gender. And there are further diagnostic criteria described. So the diagnostic criteria are quite strict. So rather than just an incongruence for at least 6 months, you have to have had 2 of the following characteristics. So the incongruence between the expressed gender and the primary or secondary sexual characteristics. So, for example, chest development, hair development, things like that. A strong desire to be rid of one's primary or secondary sexual characteristics because of this incongruence. A strong desire for the primary or secondary sexual characteristics of the other gender. A strong desire for being the other gender or alternative gender. And a strong desire to be treated as of the other gender. And a strong conviction or a strong conviction that one has the typical feelings or reactions of another gender. So this is usually diagnosed by mental health specialists. And gender questioning in itself is not gender dysphoria. So it's interesting because self-reported transgender identity is seen in about 0.5 to 1.3% of children, adolescents, and adults but the actual prevalence of individuals meeting the strict criteria of gender dysphoria is about 0.05 to 0.01% of all adults assigned as male at birth, so natal males, or even rarer, 0.02 to 0.03% of adult natal females. So why are there gender identity issues, specifically in Klinefelter syndrome? So Klinefelter syndrome are thought of as genotypically male because of the presence of the Y chromosome and because of the presence of testes, which develop. But this development, along with the other secondary sexual characteristics, especially at puberty, is delayed and much slower. So you see, for example, breast tissue development, so gynecomastia, sparse body hair development as well, and also the or lack of development of the testis size. Alongside that, you have the psychological impact of having an extra female chromosome, as some people refer to the X chromosome as. And also there is an added issue of the exposure in the womb to less androgens, testosterone, and so on in Klinefelters compared to non-Klinefelters children, male children. So in research nowadays, there is a potential genetic basis as well of gender dysphoria that's been bandied about. So it could be due to variations in estrogen receptors and androgen receptors in trans individuals, and all that we don't know yet. All that might be related in some degree to the presence of the extra X chromosome in Klinefelters. So how common are gender dysphoria and gender questioning in Klinefelters? Well, we know that gender questioning has been associated with Klinefelters since the 60s. In a recent study of participants with various disorders of sexual development, or DSDs, 1 in 209 patients with Klinefelters were found to have current gender dysphoria, and 5 out of 219 patients reported feeling either not entirely male or female, or not feeling that they belonged on the gender binary. And so we think that, this study thought that the results could have been higher, but because Klinefelters is not associated with the ambiguity at birth in the genitals that some disorders of sexual development are. So the gender dysphoria looks like it's slightly lower than other DSDs. So, but interestingly, in a recent, very recent review of 11 papers of more than 1,000 transgender individuals, about 1% of the individuals within this group, this large group of papers, were actually patients with Klinefelter syndrome. And in the patients that had actual karyotypes to confirm the Klinefelters, the prevalence was quite close to 1% as well. So although Klinefelter syndrome can be easily assigned at male birth because of the presence of the male genitalia, they can still experience gender identity issues later in life. And later questioning, so late gender identity issues have been shown in quite a few case studies in patients with KS. Also interesting is research that shows that the severity of gender dysphoria in Klinefelters may differ compared to other areas. So it seems like there's a spectrum of gender questioning in KS where individuals have a lower GIDYQ score. So these are scores that indicate gender identity issues. So they have a lower score than control or cisgender male controls, but not enough to be diagnosed as gender dysphoria. So low scores mean there is some gender identity issue, but the cutoff for gender dysphoria is quite low. So although there is questioning, there may not be gender dysphoria. And interestingly, the greater the degree of questioning or dysphoria, the more likely you have an autism spectrum related to the KS diagnosis. So this is also very recent research. The other question, along with the prevalence question, is what is the role of testosterone in this whole gender dysphoria issue? Because if physical characteristics play a part in your gender identity, perhaps testosterone has a part in helping with this, or so the theory goes. So there are some case studies that describe KS patients whose gender dysphoria is improved by testosterone replacement therapy, perhaps by masculinizing the physical effects of low testosterone. So basically balancing out things like reducing gynecomastia, for example, and also reducing depressive symptoms. Also, TRT has been suggested to change the interpretation of the concept of self in some patients with KS. And in fact, there was one case study of a KS patient raised as a female who was very keen to transition to becoming male. And the theory there is that because the KS patient in question had higher testosterone than a female, the age in general, that led to this feelings of wanting to transition to male. But why does this matter? Why do we need to know about gender questioning and gender dysphoria in KS? Well, transgender individuals have greater rates of anxiety, depression, and suicide. And KS patients themselves have an increased prevalence of mental health issues. Beyond that, when you transition, you do have to take hormones, estrogens, in the case of changing from male to female. And this brings up lots and lots of different issues. For example, venous thromboembolism risks, already high, we think, in Klinefelters, made higher by adding estrogens to the equation, potentially. And also things like breast cancer, much higher prevalence in Klinefelters. And if you add in the estrogen, progesterone hormones, which also have a high risk of breast cancer, you're adding this risk on to patients wanting to transition. So all the different treatment considerations come to play as well in this cohort of Klinefelter's patients. Also, as we understand more and more about Klinefelter's, we need to support the holistic management of Klinefelters, with dysphoria being part of this holistic management, at least the identifying of gender dysphoria or gender questioning and addressing the issues there. So we know that there's an unmet need to determine how common gender dysphoria and gender questioning is in KS, and perhaps establish some standards of care for these patients. But it's difficult itself because Klinefelter's itself is underdiagnosed in the population. In 70%, actually, it's not diagnosed. So one important aspect of this whole research is screening for Klinefelter's in gender dysphoria clinics to understand outcomes in Klinefelter's patients, but also screening for gender dysphoria and gender questioning in patients diagnosed or followed up for Klinefelter's, because it allows us as clinicians to identify individuals who may need more counseling and refer those on who have really quite deep set issues, which are really what the gender dysphoria definitions are meant to pick out. So to start this process of implementing screening tools, we need to understand, first of all, how Klinefelter's individuals see gender identity as a population. So what we did in our clinics, basically with the United Kingdom, the UK's Klinefelter Association, was we developed 23-point questionnaires of Klinefelter patient attitudes to gender identity. And this was developed through multiple rounds with multiple clinicians, gender psychiatrists, urologists, psychosexual medicine specialists, endocrinologists, over the course of a year. And then the questionnaire itself was circulated to Klinefelter's patients within the Klinefelter Association and patients in our multidisciplinary clinic. So 114 patients responded. But what was interesting was that only 55% of the respondents identified fully with the male gender. 90% of the patients who responded are registered as male on their birth certificate. 10% had actually changed their sex on their birth certificate to female. And 19% reported that they did not enjoy living as the sex on their birth certificate. And these are men who were registered as male. So the mean participant age was 55, so not a young mean age, and the majority of the patients were white Caucasian. Also, 55% of the respondents felt that some of their physical characteristics did not match their gender. So nearly half of them were considering changing aspects of their physical appearance to better match with their perceived gender. So the most common area that they wanted to change was the chest and breast area, followed by body shape, and then the genital area and body and facial hair. Also very interesting is that most patients, but not all who identify as male, preferred being on testosterone replacement therapy. And the ones who didn't, but identify as male, most of them wanted to be on TRT for its physical changes. But still, up to 1 in 5 patients who are on TRT did not see themselves as exclusively male. And in fact, one patient on TRT had gender dysphoria after starting TRT. In contrast, all patients on estrogens prefer to be on estrogens. Some were at the start of their transition journey. Some were previously on TRT, and some were awaiting to be on estrogens. So 11% of the patients in this group were receiving estrogens. Also, 5% of patients shared experiences of being let down by the medical system in terms of gender identity issues. They reported feeling mocked because some clinicians did not understand gender identity issues in Klinefelters. And I think that was the main source of frustration, that healthcare professionals did not know how to address or identify gender identity issues and potentially gender dysphoria. And there are instances as well where patients were denied access to gender-related services because their Klinefelter syndrome. So we've had lots of different anecdotal excerpts from our patients, from being refused estrogens despite having gender dysphoria, to patients being told they had mental health issues when they brought up gender identity and gender questioning issues in one case, to their endocrinologist. So what is the future? The current data suggests that much more research is needed in this area. First of all, to understand the impact of gender questioning and gender dysphoria in Klinefelters, and perhaps developing some tools to help assess this, the severity of this in Klinefelters, because there is such a unique interplay in Klinefelters between gender questioning and the physical characteristics and so on that we've just shown. And also with that, defining the role of testosterone and other hormone replacement therapies, because testosterone itself doesn't seem to be the fix that people think would alter gender questioning issues in a lot of patients with Klinefelters. So it's not a clear-cut issue. Lots of work needs to be done. But for now, what we can do is clinicians can start the conversation to explore and address identity issues amongst Klinefelter's patients. And this is to ensure that a plan can be put in place to help patients in this path of understanding their gender identities. Most trials, including our research, have biases. One is ascertainment bias. So we're asking groups of patients about the gender identity. So obviously patients who have issues are probably more likely to respond to such surveys. And there's no control group in a lot of research out there right now, small sample sizes. And even with our research, there's a lack of diversity. So other patient groups, racial patient groups are not often factored into this in terms of respondents and so on. So these are things we need to address in future research as well. But what else can we do now? Well, patient and parent awareness of these issues is very important. And the support of organizations like the AXYS and in the UK, the Klinefelter Association, are vital in helping patients who are struggling with gender identity issues access the resources they need. So I've given here two snapshots of good websites. The first is the Gender Identity Development website in the UK, which has helplines and help websites to access. And also the Mayo Clinic website, which has some suggestions and tips for families whose children are going through gender identity issues to create a safer environment for these children. So these are the references for my talk. And thank you very much. I'll take any questions and thank you.